Hello everyone, welcome to this session. In this session, we are going to talk about a chapter, endometriosis. So let's begin with a quick recap of the chapter, endometriosis. Now, what exactly is endometriosis? It means when the endometrium tissue is present outside the uterus. In simple words, we can mention the ectopic endometrium. In simple words, we can mention that ectopic endometrium present outside the uterus. Present outside the uterus. Now, if we talk about the etiology of this endometriosis, we have different theories, and the most common theory that has been accepted is called as Sampson's theory. The theory is called as Sampson's theory. Now, what exactly is this Sampson's theory? It says that the endometriosis, it is due to the backflow of menses. It says that it is due to the retrograde menstruation. It's due to the retrograde menstruation. That means the backflow of the menses. If we talk about the age group that has been commonly affected with the endometriosis, it's going to be around 25 to 35 years of age. It's going to be 25 and 35 years of age. And the investigation of choice is going to be laparoscopy. The investigation of choice is going to be laparoscopy. And the gold standard, if they ask gold standard investigation, then your answer is going to be histopathological examination. Then the answer is going to be histopathological examination. The investigation of choice is a recall question from your exams. What was the question was simply asked, what is an investigation of choice for endometriosis? Your answer is going to be laparoscopy. And the laparoscopy in case of endometriosis can be used as diagnostic as well as therapeutic. Is that clear? Now, if we talk about the most common site of the endometriosis, that the most common site is going to be ovary. And the second most common site is going to be pouch of Douglas. The second most common site is going to be pouch of Douglas. And that's why when there is endometrial tissue present in the pouch of Douglas, the patient complains of a dyspareunia, that is a pain during the intercourse. Now, if we talk about the least common site, that is going to be CNS and spleen. That's going to be CNS and spleen. Okay, if we talk about the pathological features or the laparoscopic features of the patient having an endometriosis, we are going to have a powdered burn lesions. Number one thing that you will found in your clinical cases, powdered burn lesions. On laparoscopy, we'll see a cyst over there filled with the old blood, giving a picture of a chocolate cyst. This is going to be the chocolate cyst of the ovary. Why there is a chocolate color? Chocolate cyst of the ovary, because of the old blood. Okay, what is inside the cyst, sir? Inside the cyst we have old blood. Okay, and this is a laparoscopic view of a chocolate cyst of the ovary, and these are exactly what powdered burn lesion, the laparoscopic view of powdered burn lesions. Let's move to some other pathological features. We have second one, chocolate cyst of the ovary. Chocolate cyst of the ovary, and this endometriosis can be found in the uterosacral ligaments. So on examination we have a uterosacral ligament nodularity. We have uterosacral ligament nodularity. Uterosacral ligament nodularity. Okay, so if we talk about the clinical features now, what exactly are the clinical features of a patient having endometriosis? The first feature is going to be patient will complain of a pain during the menstruation. That's going to be dysmenorrhea. Patient having pain during the menses is called as dysmenorrhea. Okay, then patient have a painful intercourse. That is going to be your dyspareunia. Dyspareunia, and a patient will have heavy bleeding more than 80 ml. That is menorrhagia. That's going to be menorrhagia. Apart from that, due to the scarring and adhesions, patient is going to have scarring and adhesions. Due to the scarring and adhesions, patient is going to have infertility. क्या होगा patient को? Infertility. So usually Infertility is rare, but yes, it is again associated with an endometriosis. So you have a classical clinical picture of a patient who is coming to you with the complaints of dysmenorrhea, dyspareunia, along with the age around 25 to 35 years old, having a cyst. Your likely diagnosis is going to be endometriosis. Now, if the examiner will ask the investigation of choice, your answer is going to be the laparoscopy, and the gold standard investigation is going to be, yes, it's going to be the histopathological examination. Histopathological examination. Okay, clear? Remember these important points: powdered burn lesions, chocolate cyst of the ovary, and uterosacral ligament nodularity. Because examiner can mention these findings in the question, that's how you have to answer that. Clear? Now, if we talk about the treatment of endometriosis. Now, if we talk about the treatment of endometriosis, first of all, we have a medical management. First of all, we're going to discuss about the medical management. And in medical management, first of all, mild symptoms and then moderate symptoms. Very few symptoms, minimal symptoms, and the mild symptoms. If we talk about for the mild pain, the first line treatment that we give, is OCPs. Okay, the first line treatment in case of a mild pain we are giving, that's OCPs. Okay, but if patient wants to conceive, then stop OCPs and give NSAIDs for the mild pain. Okay, then stop OCPs and give NSAIDs for the mild pain. Second thing, that's going to be second line drugs for the usually that we give, that's going to be progesterone. And we can give progesterone either in two ways. We can give a intrauterine contraceptive device containing a progesterone, and you already know that the third generation of the IUCDs containing progesterone, levonorgestrel, and the classical example is going to be Mirena. Either we can use Mirena or we can use injection depot medroxyprogesterone acetate. What is an injection, guys? Depot medroxyprogesterone acetate. Okay, and we have to use this injection 150 mg once every 3 months. We have to use this injection 150 mg once every 3 months. And this DMPA is also used in a one contraception. They can give you the classical picture of a contraception, Antara, and they will tell you what is the medication inside. You have to answer DMPA. And what is the name of contraception? That's going to be Antara. Okay. And followed by that, we can use drugs also, GnRH analogs. We can use drugs like GnRH analogs like naferilin, buserelin, goserelin, and all. Is that clear? And main drug that we use to cause an atrophy of the endometrium. Now, what exactly is a function of this DMPA? Sir, what exactly is the action of this DMPA? It causes atrophy of endometrium. But the drug danazol, causes faster atrophy of the endometrium. Now we already know which hormone helps in the proliferation of the endometrium. That's going to be estrogen. Okay, if you already have studied in the main cycles that first 14 days there is a proliferative phase. That means there is a proliferation of the endometrium. And what is the hormone that will help in the proliferation of the endometrium? That's going to be the estrogen. Now when I'm using a danazol, and the danazol has anti-estrogenic action. Danazol has anti-estrogenic action. That means if estrogen is causing hypertrophy, danazol will cause atrophy. Exactly. So what is that? It will cause faster atrophy of endometrium. It will cause faster atrophy of endometrium because it has an anti-estrogenic action. But they can ask you the side effect of this particular drug, bacho. What is the side effect? The side effect is it causes virilization. It causes virilization and it causes hirsutism. So two side effects, you remember, virilization and hirsutism. What exactly I mean by the virilization? Three components. Patient will have a breast atrophy, patient will have a clitomegaly, and the hoarseness of voice. And when exactly to stop the drug? When exactly patient has hoarseness of voice, stop the drug, danazol. So it was about a medical management. So in medical management, remember, first one is going to be OCPs, NSAIDs, progesterone, GnRH analog like naphirillin, glucirilin, okay, and danazol having an anti-estrogenic action. And we should go for more medical management because patient is usually what? Young, family might not be completed. So medical management more. Okay. Now, if we talk about a surgical management of if we talk about a surgical management of an endometriosis, I've already discussed that a patient will have adhesions there, and for adhesions I'm doing adhesiolysis. For adhesions I'm doing adhesiolysis. Okay. For chocolate cyst, I will do cystectomy. For chocolate cyst, I will do cystectomy. And it was a question asked that what is an ideal treatment for a recurrent chocolate cyst? What is an ideal treatment for a recurrent chocolate cyst? That is an FMGE recall Jan 2023. Your simple answer is cystectomy. They will write cyst ablation. Okay. They will write cyst ablation, cyst thermal laser. Correct answer is going to be cystectomy. Okay. For deposits or powder burn lesions, for these deposits, we are going to do ablation or fulguration of these deposits. We can also go for a pre-sacral neurectomy. Pre-sacral neurectomy. Okay, or either we can go for a lasers. We can go for thermal lasers, but thermal lasers have recurrence. So best part is you go for additions, adhesiolysis, and for chocolate cysts, you go the cystectomy, and for these deposits, you go with the ablation. That's going to be the surgical management of the endometriosis. That's going to be a surgical management for the endometriosis. Now, let's discuss some clinical cases on this chapter so that this quick recap will help you in the exams, coming up exams. Okay. Now, a clinical cases over there, a woman having an age of 32 years old. Okay. She is presenting to the gynecologic clinic with the complaints of a chronic pelvic pain and dysmenorrhea. So already two symptoms: patient having an age between 25 to 35, patient having a dysmenorrhea that has burned over the past year. She describes the deep dyspareunia. I told you patient will have a deep dyspareunia due to the endometrial tissue present in the pouch of Douglas. So patient complains of a painful intercourse and occasional bleeding of blotting. Her periods are regular but are associated with dysmenorrhea. On examination, she has tenderness in the lower abdomen, particularly in the adnexal region. The TVS reveals there is a 4 centimeter hypoechoic homogeneous cyst. So there's a cyst in the left ovary. What is your likely diagnosis? So my dear students, a 32-year-old lady coming to you with the complaints of dysmenorrhea, dyspareunia, cyst in the left ovary, your classical diagnosis is going to be, sir, endometriosis. Your classical diagnosis is going to be a endometriosis. So why not ovarian cancer? The patient will have a cancer-like features, a weight loss, cachexia and all. Why not PID, sir? Patient will come of an infection. Patient will have an increased TLC counts. Patient will complaining of the fever and other features. Any discharge? Why not PCOS? Patient will complaining of hirsutism, acne, anovulation, amenorrhea. All that Rotterdam criteria will fall into the place. So the classical answer of this question is going to be endometriosis. Is that clear? The next question, guys. A 30-year-old woman who presented with a secondary dysmenorrhea has been diagnosed with an endometriosis. So there is a female having secondary dysmenorrhea, or secondary dysmenorrhea. Sir, what exactly is secondary dysmenorrhea? It means when the pain starts 3 to 4 days prior to the cycle. That's going to be your secondary dysmenorrhea. What is dysmenorrhea? Dysmenorrhea is a pain during the menstruation. And what is primary? Primary means when the patient will have a pain before the onset, like 30-40 minutes prior to the cycles, patient will start a pain. That's going to be primary dysmenorrhea. And what is secondary dysmenorrhea? When this patient complains of a pain 3 to 4 days prior to the cycle. Okay, so a 30-year-old woman presented with a secondary dysmenorrhea has been diagnosed with an endometriosis. So remember that secondary dysmenorrhea is seen in endometriosis as well as PID. Classical two things where you can find the secondary dysmenorrhea. Patient having endometriosis and PID usually have a secondary dysmenorrhea. That means the patient will have a pain 3 to 4 days prior to the cycle. Now, which of the following drug is not useful in this treatment? Now, my dear students, we have already discussed the drugs. What are the drugs that we use? We use OCPs, we use GnRH analogs, we use progesterone, Mirena or DMPA, or we use a danazol having an anti-estrogenic action. Now, progesterone, yes, sir, we use in the form of Mirena and IUCD containing LNG, or second one is going to be your DMPA, depot medroxyprogesterone acetate. So danazole, yes sir, we use having an anti-estrogenic action. GnRH analogs, yes, we use like nafarelin and buserelin and all. Do we use estrogen? No, sir, we don't use estrogen. The main goal in the endometriosis is cause the atrophy of the endometrium. Now, if I'm giving estrogen to the patient, what will happen? It will cause proliferation of the endometrium, and proliferation of endometrium we don't need. So we need atrophy of the endometrium. So the drug that is not used is going to be your estrogen. That's going to be your estrogen. Is that clear? So this was a quick recap of the chapter of endometriosis, so that it will be helpful in your coming up exams, FMGE. Okay, so let me give you a quick revision again. I started with the fact, and I started with the chapter endometriosis. What exactly is endometriosis? It means when there is an ectopic endometrium present outside the uterus. The reason can be retrograde menstruation. What is the reason? Backflow of menses. The age around 25 to 35. Investigation of choice is going to be laparoscopy. If they ask the gold standard, your answer is going to be histopathological examination. Okay, the most common site is going to be ovary. Second most common site is going to be pouch of Douglas. If I talk about least common, CNS and spleen. The pathological points you will remember: there are powdered burn lesions, there is a chocolate cyst of the ovary, and there is uterosacral ligament nodularity. In clinical case, my dear students, these three things will be mentioned. Have an idea that it's going with the endometriosis. It's going with the endometriosis. The patient will have a classical symptoms like dysmenorrhea, pain during the menses, dyspareunia, patient will have a painful intercourse, menorrhagia, patient have a heavy bleeding more than 80 ml. Okay, normally it's 30 to 35, but in case of an endometriosis, it goes up to 80 ml. And due to the scarring and additions, patient will complain of an infertility. Patient will complain of infertility. Okay, the medical management, the drugs that we use OCPs, we use progesterone, we use NSAIDs, and NSAIDs we'll use when the patient wants to conceive. We use GnRH analogs that will do the down regulation of the pituitary. Okay, we use injection depot medroxyprogesterone acetate. Okay, we use progesterone containing IUCD, Mirena, and this DMPA, I've told you one more extra point, that it's used in a contraception called as Antara, and the dosage over is same 150 mg once every 3 months. And second is going to be danazole, which has an anti-estrogenic action, which will cause a faster atrophy of an endometrium. What are the side effects? First one is going to be virilization, and second one is going to be hirsutism. What exactly is virilization? It means breast atrophy, clitomegaly, and hoarseness of voice. And when exactly will stop the drug? When a patient will complaining of a hoarseness of voice. So surgical management, for additions, I will give adhesiolysis. I'll go for adhesiolysis. For chocolate cyst, I will do cystectomy. Okay, for deposits, I'll go for the fulguration of these deposits or the ablation of deposits. We can go for pre-sacral neurectomy. And we can go for thermal lasers as well, because they have a recurrence. We can use thermal lasers, but because they have a recurrence, we don't usually go for that. Okay, so this was a quick recap of the chapter endometriosis. Watch it once, and we'll come with more chapters like that. Till then, keep studying. Okay, and you got this. All the best. Thank you.